Good evening, everyone. Welcome to the Deakin University Optometry Alumni webinar, Therapeutic Refresher. And welcome to our presenters, Ereeny Mikhail, Khyber Alam, Professor Alex Gentle, Dr. Simon Backhouse, and Natalie Watt. I'm Amanda Edgar, your co-president of the Deakin University Optometry Alumni Chapter. And today we're broadcasting live with the Alumni Committee, which includes Zara, fellow co-president, and the amazing committee members, Ash Chan and Lucy Ainge. Moving on. I'd like to take a moment before we begin to acknowledge the traditional custodians of the land we have gathered on today. I pay my respects to the elders past, present and emerging, for they hold the memories, the traditions, the culture and the hopes of Aboriginal and Torres Strait Islander people across the nations. An important announcement before we begin today, we would like to inform you that the Geelong ophthalmologists have decided to bulk bill anyone who identifies as an Aboriginal or Torres Strait Islander. This exciting initiative is aimed at closing the gap. Our part to play as optometrists to help our patients is to identify on our referrals if a patient declares to be an Indigenous Australian. We are being encouraged to ask the question. This is important not just for the appointment fee, but also so we deliver culturally appropriate care. We show that we understand self-identification is important, and we understand it will improve the monitoring and evaluation of services to help understand our community's needs. So asking the question makes us a really important part of attempting to change the statistics and the impact of the three leading causes of vision loss in Aboriginal and Torres Strait Islander people. So thank you to Jodie Phillips for putting together this information for us tonight. And if you're interested in resources to support you asking the question at work, please visit the chat box where you find some resources put together by the University of Melbourne. For those watching at home or those that couldn't make it, please don't stress. Today's webinar will be recorded and posted online at the Deakin Alumni website under Webinar and Resources.
Okay, before we get started, you may notice that your microphone has been muted for the duration of the presentation. We encourage all participants to use the Q&A box, see the bottom of your screen labelled Q&A box, to submit any questions to the presenters, which will be answered at the end of their presentation. If time does not allow for this, the questions will be answered and posted in this box for all to see throughout the presentation, so fear not, it will be done. Please remember that your attendance for the entirety of this webinar is important and being monitored so that you can claim your CPD points. Tonight, you will receive 3 therapeutic CPD points for attendance alone. If you successfully complete the online assessment, you will receive 4.5 therapeutic points. Please notice that there is a link to your Qualtrics survey for CPD in the chat box so that you can access this throughout the presentation. And moving on.
So again, welcome to the 4th Optometry Alumni webinar, Therapeutic Refresher, where we are connecting with over 300 alumni and friends of the alumni across the country. We are proud to have our first speaker today, Ereeny Mikhail, one of our very own alumni who graduated from Deakin University in 2018 and is currently undertaking her PhD at Deakin as well. Ereeny obtained her Bachelor of Vision Science and Masters of Optometry and Ocular Therapeutics endorsement from Deakin University in 2018. Since graduating, she has worked in a range of clinical practices where she has diagnosed, managed and co-managed a large range of ocular diseases. She has also taken part in volunteering in Kenya, providing optometry services, and she hopes to continue volunteering internationally and rurally. Ereeny has also been heavily involved in research. During her time at Deakin, her master's research project focused on contact lenses. She presented this at CMO and SRC conferences. She is currently undertaking her PhD focusing on ocular allergy. She has published an article surrounding this topic for which she received an Outstanding Publication Award by the Impact Institute, and she has submitted a second publication. Additionally, Ereeny spends time on other research topics such as keratoconus with Dr. Sarap and from Deakin University. Her future interests are research regarding the anterior eye. Tonight, Ereeny will be providing a short overview of her PhD research. Over to you, Ereeny.
Thank you, Amanda, for that kind introduction. So as Amanda mentioned, I'm currently doing my PhD project at Deakin University under the guidance of Associate Professor Cenk Sofioglu, Dr. Sarap Azizoglu, and Dr. Manisha Gokhale. My project title is Symptoms, Signs and Biosignatures in Ocular Allergy, Revolutionizing the Health Practitioner Approach. So my project is split into two major sections, as you can see in the title, and I'll go into that further in the presentation. So here is my talk outline, and I've also put it at the bottom so that you can keep track of what I'm up to. I'll first in a lot of detail provide introduce the topic and provide a rationale for research in the area. Then I'll go into the first part of my research, which focuses on the patient side of things. This is looking at finding predictors to ocular allergy. That way we can diagnose and manage our patients earlier. The second part of my research is on the practitioner side of things, and that's basically looking at ways to improve the diagnostic, treatment, and collaborative care approach of health practitioners involved in ocular allergy. And then I'll conclude the talk. So the learning outcome is to understand the current knowledge on ocular allergy and some of the gaps in the literature on ocular allergy. So what actually is allergy? Allergy, or an allergic reaction, refers to signs and symptoms experienced by an individual to an otherwise harmless substance. Such substances include pollen, fungal spores, insects, food, and drugs. This can occur when an individual is genetically predisposed, but can also occur because of environmental and social factors. Specifically, ocular allergy is an allergic reaction in the eye, which can occur directly to that harmless substance or in conjunction with common allergic conditions, such as eczema and hay fever. So why is it important to be conducting research in ocular allergy? So once the allergen interrupts the ocular region, the inflammation begins, which then leads to ocular itching. This is the hallmark symptom of ocular allergy. Ocular itching poses a problem as it leads to eye rubbing, and eye rubbing leads to keratoconus. As we know, keratoconus is a progressive disorder which results in the thinning of the cornea. This results in visual disturbances, and with progression of the disease, corneal cross-linking becomes difficult. Patients then have to undergo further treatments and eventually experience loss of vision, such as through corneal perforation. This then requires a corneal transplant, which obviously has further complications, and overall the patient has a reduced quality of life, as you saw in that meme I put on the first slide there. So the main objective of my research is basically to be diagnosing these patients earlier, so before the ocular itching, so where my red arrow is over here. I'd also like to know that keratoconus is particularly prevalent in adolescents, so these can be occurring in that younger age group. Further to this, there's also been evidence that ocular allergy leads to disruption of the tear film, and ocular allergy leads to decreased quality of life, physically, emotionally, socially, and economically. Apart from the patient side of things, we need to assess things from the practitioner side of things. So what does the literature say in terms of what health practitioners are currently doing? A study conducted in 9 countries, which explored the differential diagnosis of red eye, found that ocular allergy, specifically allergic conjunctivitis, was the most common diagnosis during allergy season. However, the agreement in the diagnosis between ophthalmologists and GPs was only 48%. This shows that there is a huge lack of consensus in the diagnosis or the way we diagnose ocular allergy. Further to this, a questionnaire exploring the burden of allergic rhinitis was conducted in Europe and the US, where the patients had nasal and ocular symptoms and were receiving treatment. However, it was found that practitioners reported the condition less severe than that reported by the patients. This means that perhaps they were undertreating the patients because they didn't gauge the severity of the disease. And finally, in Australia, the primary care practitioners involved in ocular allergy are optometrists, ophthalmologists, GPs, allergists, and pharmacists. However, there is currently no literature on the collaborative care of these health practitioners. This means that we not only need a clearer diagnosis and treatment, or like a better consensus for diagnosis and treatment, but we need a better collaborative care model. This will alleviate the confusion between the healthcare practitioners, as you can see I put in the diagram on the side there, and it will give an overall better outcome for the patient. So let's briefly go into ocular allergy. There are different types of ocular allergy, which are classed as acute, chronic, or other forms. The 2 acute forms are seasonal allergic conjunctivitis and perennial allergic conjunctivitis, which are the most common. A study which assessed 1,079 eye allergy cases found that 81.2% of those cases were SAC and 10.6% were PAC. And these are both type 1 hypersensitivities, but I'll go into the importance of that in the next few slides. Basically, these are the symptoms and signs, and they're the same for both conditions. The main difference is over here boxed in red, and most of us know that already. So these are the types of ocular allergy I will be including in my first half of my research, as the primary aim is to diagnose these patients earlier. So we want the acute forms and not the chronic or other forms, as they would have already manifested signs and symptoms and completely different biosignatures in their types of hypersensitivity. But I'll still quickly go through them. So the chronic forms are vernal keratoconjunctivitis and atopic keratoconjunctivitis. The same study, which assessed the 1,079 eye allergy cases, found that 3.8% of those cases were VKC and 4.4% were AKC. These are both type 1 and type 4 hypersensitivities, and that's the difference there. And the boxes here in red are the characteristic factors of the two conditions. The other forms are giant papillary conjunctivitis and contact blepharoconjunctivitis. There is a debate over whether these should be included in the disease group. However, many authors do still classify them as ocular allergy. These differences lie in the fact that GPC is not a true hypersensitivity reaction, and it has an abnormal inflammatory response, and CBC is only a type 4 hypersensitivity. And the red boxes here are the characteristic factors of the two conditions. So a type 1 hypersensitivity reaction, which is present in acute and chronic forms of ocular allergy, is known as an immediate type hypersensitivity reaction, which requires antibodies to occur. As demonstrated in the diagram I've created here, it begins when an antigen-presenting cell captures the antigen, such as allergens from pollen. It then presents it to a naive T helper cell, which proliferates as a Th2 cell. The B cell is then turned on, which matures into a plasma cell and releases IgE antibodies that are highly specific to the antigen. These are then bound to mast cells, which then circulate. At the next antigen presentation, the IgE molecules cross-link and the mast cells degranulate, which release histamine amongst other inflammatory mediators. I've highlighted the histamine here in red, as it's what causes the ocular itchiness, which is, as we said, the hallmark symptom of ocular allergy. But the most important thing we need to remember from here is that there are specific cytokine biosignatures which precipitate this reaction. And after the first exposure to the antigen, we believe that these biosignatures linger around in the eye. Since this is a type of hypersensitivity that is present in acute forms, I'll go into less detail for type 4 hypersensitivity. So a type 4 hypersensitivity reaction, which is present in the chronic forms and is a primary reaction in CBC, is known as a cell-mediated response, meaning it does not need antibodies to occur, but rather cells such as T lymphocytes. And as you can see from here, it's a far more complicated response. So basically the first part of my research will combine the three discussed factors. So the symptoms, signs, and biosignatures. We'll collect this via the use of questionnaires, optometric clinical assessment, and lab assessment. We'll collect this data from a group of patients, then we'll follow up these patients through the seasons of winter, spring, summer, and then autumn. And that's basically so that we can find patterns in what's happening in this data. And basically we'll be correlating that with the allergens that we'll identify through air sampling, such as pollen or fungal spores. Basically through this, we're hoping to find a predictor to ocular allergy, and we're guessing that it could most likely be the biosignatures, but obviously we'll see. So that's for the patient side of things. For the practitioner side of things, basically our patient comes in, we go through that three-step approach: patient history taking, practical diagnostic methods, and management and treatment methods. And I'll go into that in a bit more detail. So basically for our patient history taking, we ask them ocular allergy specific questions, questions to eliminate differential diagnosis, and quality of life questions. I've actually published an article on questionnaires that currently assess the quality of life of ocular allergy patients, and I can link that in the chat box below. For our diagnostic methods, we go through ocular allergy specific testing. This is things such as slit lamp assessment, systemic testing such as the skin prick test, and lab assessment, which includes, as we said, our biosignatures, but could also include IgE analysis. And finally, our management and treatment methods are prevention strategies such as avoidance of the allergen, therapies such as cold compresses, topical drops, which include our allergy-specific drops, steroid drops, etc., and our systemic treatments, which is such as immunotherapy. So the health practitioners involved in the collaborative care of ocular allergy are GPs, ophthalmologists, allergists, pharmacists, and of course us optometrists. So basically my second part of my research will be administering a survey, which will assess these three factors. So the diagnostic, treatment and collaborative care of these health practitioners. What we're trying to find is basically the gaps in what we're doing so that we can find improvement to the approach. And I have a second article on that, which is currently under review, which has a lot more detail on this. And I just want to thank everyone here on this slide. I think anyone who's watching who is a PhD student knows what it's like to go through PhD. It's never really an easy path. There's always bumps, and this year with the huge, not a bump, but more a mountain of COVID. So I just want to say thank you to everyone here who supports us at Deakin. And if you have any questions, please send them in the Q&A box below. Thank you.
Thank you, Ereeny, for your presentation. So if anyone has any questions about Ereeny's presentation, I would now like to invite you to use the Q&A box, and we will answer them throughout the night. But firstly, Ereeny, to just get you started, just tell us why you picked your PhD topic. What drew you to it?
So I was in practice and I saw a lot of keratoconus and ocular allergy, and that was just in Sydney. So I ended up moving to Melbourne, which is the allergy capital, the allergy capital of the world, basically to explore this a bit more. So it was just seeing patients who were really unaware that their ocular allergy was leading to these negative effects. And I just remember one specific case of a mother who had very bad ocular allergies and basically rubbing her eyes all the time. This led to keratoconus. And then when I referred her, the ophthalmologist, he basically, confirmed my suspicions. And I remember it was just too late for corneal cross-linking, and it was a bit like traumatizing for her. So that drew me a lot to the topic. And also it was great to have, my supervisors who are very excited about the topic too, and also explore the same thing. So that really encouraged me to actually go into it.
So I'm going to give you some time now to answer any questions in the Q&A. So now you can rest and relax. Okay, so we'll move on to our next presenter. So our next presenter is another Deakin alumni who graduated in 2016 and is also completing his PhD research with Deakin University. Khyber was born in Pakistan, where his parents arrived as refugees from Afghanistan during the Soviet-Afghan War. He settled in Afghanistan in late 1990s, but later arrived in Australia as a 13-year-old boy after the 2001 war in Afghanistan evolved out of September 11. Khyber has experiences as an educator, researcher, clinician, founder, and executive manager of a humanitarian organisation. Very impressive. He's extremely passionate about serving our global community through affordable, sustainable, and up-to-date healthcare and educational services. His research interests include neurodegenerative retinal diseases, pediatrics, public health, vision impairment and its impact on the quality of life, and evaluation of eye care and educational services. I'm now going to hand it over to Khyber to tell you a little bit more about his research.
Thank you, Zara. Thanks, everyone. So I'll jump straight into it. First of all, it's such a pleasure to present alongside my mentor, Alex Gentle, and all of the other amazing presenters as well. So the issue which prompted me to look into this topic was that several clinical trials have demonstrated the effectiveness of low vision rehabilitation services, but we have about 20% of Australians with vision impairment that access these services, although trials indicated that about 90% of them could benefit should they attend. Next, Sam, thank you. So in Australia, we define vision impairment in the early stages as distance visual acuity of worse than 6/12 in the better eye, or a constriction of visual field. And next, Sam. So the global prevalence of vision impairment is quite significant as well, where in 2015, a study concluded that about out of the 7.33 billion population, we had almost 36 million people with blindness. We had about 216.6 million people living with moderate to severe vision impairment, and about 188.5 million individuals who had mild vision impairment. So the leading causes of vision impairment were 42% uncorrected refractive error and 33% cataract and 2% glaucoma. If we look at the first two, which are uncorrected, sorry, if we can go back, Sam, thank you. So if we look at the first two, the uncorrected refractive error and cataract, we know that if we have global initiatives tackling those two, it can significantly reduce the global prevalence of vision impairment. Next, Sam. So the significance of vision loss is that it, first of all, as can be estimated by all of us, it reduces the quality of life. It increases the risk of falls by 2 times. It increases the risk of depression by 3 times. And studies have concluded that about 61% of people with vision impairments experience some sort of anxiety or stress or depression. And vision loss also increases the risk of hip fractures about 4 to 8 times, which then obviously leads to an early admission into aged care facilities by 3 years. And these patients with vision loss are twice as likely to use health services, which indicates an impact on our healthcare system as well. And vision loss overall just leads to compromised functional and emotional well-being. So the economic implications of vision impairment are quite significant both for Australia and globally. Around the world, it cost the global community about $3 trillion in 2010. And in Australia, it cost us about $16.6 billion in the year 2009. This number was actually around $9 billion in 2004. So in about 5 years, it almost doubled, which is quite significant. And the number from 2010 was estimated to increase by approximately 20%. So it'll be interesting to look at the findings now and see if that has actually happened as well. Next, Sam, thank you. So the model of care includes individuals that are involved in providing services to people with vision impairment. This model is both sort of implemented globally and as well as in Australia. So we have the 3 categories: primary, secondary, and tertiary. In the primary, next, Sam, thank you. So in the primary stage, we have community health practitioners who may be either optoms or GPs or community occupational therapists or orthoptists, or even school nurses and school teachers who would just conduct basic vision screening and prescribe any magnifiers if need be. But predominantly in this stage, people spread awareness about vision impairment and a referral is issued if need be to the secondary care. In the secondary stage, we have optoms, ophthalmologists, orthoptists, and ophthalmic nurses and technicians who would conduct thorough assessment of vision impairment, which obviously includes refraction, the diagnosis and treatment of vision impairment, and they would prescribe optical and non-optical aids and provide training regarding their usage as well. In this stage, a referral would be made to tertiary low vision clinic when a patient no longer needs the services that are only provided at this stage. So in the tertiary, there is an additional group of people that are involved. So there is a multidisciplinary care team, which would include occupational therapists. If you recall on the first few slides, I mentioned that vision impairment leads to fractures, it leads to early admission into aged care facilities, it influences mobility, it influences mental health. So this is where this team comes in really handy, because the multidisciplinary care team would provide occupational therapy services, orientation and mobility help, and also counseling. And one of the things that I found particularly interesting while I was going through my research as well, how much the patients appreciate the patient and peer support and welfare worker aspect of this tertiary care provision. So we know that we looked at the model, we saw the individuals, we know that it probably looks really clear, but in the first slide, I showed you that about 20% of people with vision impairments access these services. So some researchers around the world in Australia have looked into this to see why so fewer people access these services, although almost all of them could benefit. So the barriers can be divided into a few different categories, predominantly clinician related and patient related. We can add one more to this, which would be organizational related. So that would be things about policymakers, the shortcomings on their side, and advocacy limitations around advocacy. But if we were to look at the clinician-related barriers, some of the issues includes lack of referrals from eye care practitioners like ophthalmologists and optoms. There's an exclusion of low vision care from general optometry, although all optometry graduates in Australia have been trained to conduct low vision workup. And there's a poor payment for clinician in return for their time and skills. So there was a paper done in about around 2015 and 16 that showed that normal consultation takes about 30 or 40 minutes, but we have a low vision consultation which takes 1 hour and 41 minutes. So it's a lengthy time, and the return is not as encouraging, which could be a limiting factor. There's miscommunication between healthcare professionals that is a big issue as well when we have a shortage of advocacy. On the patient side of things, although we can't blame them for not turning up to these services, but there are some barriers identified from their perspective as well. So mobility restrictions, and most of these patients have so many other conditions that are quite debilitating that prevents them from accessing these services. So most of them have comorbidities and the level of income as well, standard of education. So in 2011, there was a study done close to home in South Australia that looked into some of the patients that attended low vision clinics, and they found that very few of them actually knew the condition that they had and the extent of vision impairment they had, and the services that were available out there as well. And most of these patients, they have this need to appear independent. And as you can understand, there's a stigma attached to vision impairment that prevents patients from accessing services as well. I've personally spoken to so many patients throughout my journey, and I've seen that some of them, although they can't even manage to walk, you know, in unfamiliar areas, but they would still not use a cane or anything like that. And in some cases, there's inadequate vision impairment to warrant low vision services, and there's a reduced perception of vision loss relative to other losses in life. As I mentioned, they have comorbidities, so they have other priorities, and vision impairment, unfortunately, is lower on that list. So all of this brought me into structuring our research and was to better understand the uptake of low vision rehabilitation services, to determine the enablers of access to low vision rehabilitation and appropriate referral criteria, and then eventually develop, implement, and evaluate a program to increase increase the access and uptake of low vision rehabilitation services. So I'm at the final stage now. Go next. The methodology for me was mixed method approach, quite similar to what Ereeny is doing. So I had demographic data, which was analyzed, significant differences between populations, and that helped us informed our second study. We had data extracted from Vision Australia, about 2,000 patients. We had focus groups with patients and practitioners, a Delphi study with experts in the field, and then a program developed, implemented, and evaluated. So the summary of my work is that we have barriers both related to patients and barriers related to clinicians. The potential impact of my work, we hope, and I'm praying that it does happen, would be to increase the referral and uptake of the services, to have an agreement on the referral criteria, which we thankfully have established that, which should or hopefully would lead to earlier and timely diagnosis of vision impairment and the subsequent treatment. And in return, an enhanced low vision rehabilitation services process in place, which hopefully should or potentially should lead to an improved quality of life in the over 500,000 Australians that are unfortunately living with this debilitating condition called vision impairment. So doing a PhD is a transformative experience. We often hope that it's something like that, nice and smooth journey, but it's often like this. And but it's this exact process that, you know, things often don't go according to your plan, that you learn so many amazing things, which includes So you have you become an oral world authority in your field by having an increased knowledge in your area. Your skills of project management improves, and personally for me, all of this has happened. Research-specific skills and building career prospects and becoming an independent researcher, being able to have and conduct effective communication with stakeholders and social, build professional reputation and gain friendships, which has been, for me personally, I have some friends that I'm sure would remain lifelong friends, and build great network as well. So you create your luck. Personal highlights been just being able to meet Alex, Heather and Sharon almost every week and learn from them, and networking, obviously, one person in particular, which I'm not sure if she was able to make it. She has a young boy, Arthur, Jack, who's an exceptional friend, and had it not been for the PhD, I'm not sure if we would have met. I was able to go to the US in 2019 with some friends as well. I would have been or would have been to Dublin, Ireland and Auckland, New Zealand, as my posters were accepted in conferences in those places, but unfortunately COVID happened. But it's all good. Soon things will be normal and we may be able to travel sometime soon. So I just wanted to thank all of the amazing people that have influenced my journey, which includes Professor Alex Gentle, who's here, and Sharon Bentley and Heather Connor and Jack Kirkman and every other person a part of Deakin Optometry. Any questions? Thank you. Thanks, Sarah.
Thank you, Khyber, for your very insightful presentation. So once again, if anyone has any questions about Khyber's presentation, again, I would like to invite you to use the Q&A box and Khyber will answer them throughout the night. So Khyber, I'm going to just give you some time now to answer all the questions. Thank you. So moving on to the next slide.
And our next presenter is Professor Alex Gentle. Alex led the design and setup of Deakin University's optometry program and is currently the Associate Head of School for Teaching and Learning in Deakin School of Medicine. His optometry training was through City University and Moorfields Eye Hospital in London, and his PhD carried out at the University of Wales. His postdoctoral research at the University of Melbourne continued his focus on biological mechanisms of ocular and refractive development and myopia control. Alex undertook his ocular therapeutics training at the University of Melbourne, and his subsequent teaching duties include ocular disease and therapeutics. So I would now like to hand over to Alex, who's going to give us a presentation on the use of restasis in optometry. Over to you, Alex.
Thanks very much, Amanda. Hopefully you can all hear me, and thanks very much for those kind words, Khyber. I'm far richer for having met you and been able to work with you. It's my absolute pleasure. So thank you very much. Next slide, please, Sam. Okay, so I'm talking today about cyclosporin, which has recently become available, or earlier in the year become theoretically available for optometrists to prescribe in Australia. So I'll give you a little bit of a history lesson first. The first application for a topical cyclosporin preparation, which was packaged as restasis, came in Australia in around 2010, and it was withdrawn in 2011, and that was mainly due to regulator concerns that the statistical evidence of the clinical trials was lacking, and that there wasn't sufficient evidence of its benefit in dry eye. For those of you who are having trouble sleeping at night, the document itself is worth a read for the end bit with the introduction, with the discussion between the sponsor and the regulator, where they're quite robust and absolutely worth a look. Effectively, the regulator felt the science was weak, and the sponsor was vigorously disagreeing with that, but he didn't get up in the end at that stage. Just before I move on, I should also point out that I've chosen to spell cyclosporin there as you see it in front of yourself. That's also how it's spelt in our optometric S4 list. You'll see cyclosporin spelt with an E on the end, or called cyclosporin A, or spelt with an I instead of the Y. They're all the same drug, and it doesn't seem to be any jurisdiction specific either. So please don't confuse yourself over that. It's all the same thing. Could I have the next slide, please, Sam? Okay, so the next thing I guess I should point out is that although Restasis didn't get up in 2011, Cyclosporin has actually been on the optometric list for a number of years, and it's been available in Australia in other forms, oral forms, for use in transplantation and to prevent rejection. So that provided the opportunity, having it on our list and the fact that it could be compounded, allowed us to use it off-label on the ocular surface, despite the fact Restasis wasn't available over here. Just very quickly, off-label prescribing is a term used when a drug's prescribed for an indication or route of administration that's not included in the Therapeutics Goods Administration or TGA approved product information. Effectively, off-label prescribing, as you'd imagine, is pretty common in Australia, and a lack of TGA approval doesn't mean that the drug is not useful for a particular indication. It just means that the TGA hasn't been asked to approve the drug for that indication. I would also point out, because I'm going to touch on this a little bit later on, that when you're prescribing newer drugs in an off-label way, it's really important to make the patient aware of this and explain why you're prescribing it and why it's going to be beneficial. And also you need to make sure that there is actually strong scientific evidence for the use of the drug off-label. So, although that may sound a little bit scary to a therapeutic prescriber, I should point out that optoms are already prescribing drugs off-label in Australia, perhaps sometimes without even knowing it. Probably you're all aware that what Simon's going to talk about in a little bit, low-dose atropine treatment of myopia, that's an off-label use of atropine. Betadine use in the management of EKC or PCF is considered off-label as well, and lodiprednol, if we ever actually get access to it in Australia, it's on our list but not available commercially over here, is actually off-label use for anything other than post-operative cataract surgery and inflammation associated with contact lens papillary conjunctivitis. So off-label prescribing is not a particular issue that you should be worried about, but you need to be aware of this. Could I have the next slide, please, Sam? Okay, so earlier this year, Cyclosporin was approved for use in Australia. It's a topical form of Cyclosporin, obviously. You can see the details there on the left. They might be a little small on your screen. It's formulated at 0.09%, so a little higher concentration than Restasis was, and it was approved by the TGA for use in 2020. The indication for use is moderate to severe dry eye, so obviously using it for anything else is considered off-label. And indeed, it's, as you'll see there, it's approved for use by administration twice daily. As you'll see later on in the presentation, you can administer cyclosporin quite safely up to 4 times a day, but using it more than twice a day would be regarded as off-label use as well. So you can now use this on label for dry eye disease. However, when I last looked, which was when I put this presentation together, Seq was still not listed in MIMS or the AMH. So at the moment, the only way to get a hold of cyclosporin in this form, Sequa, is through the Special Access Scheme, or the SAS, and of course, as optometrists, we can't access that. So fingers crossed that the manufacturers will bring Sequa into the country soon, so we can start to use it for dry eye disease. Next slide, please, Sam. Something else you need to be aware about is that the approval required Sequa to be on the Black Triangle scheme for 5 years. This is not particularly uncommon with new drugs. It occurs more frequently following TGA approval these days, and it doesn't actually mean there are any safety concerns with the drug. Usually, if a drug's new to Australia, or if a medicine's being repurposed in Australia for another purpose, it can be placed on the black triangle scheme, and all this really means is that the black triangle's associated with it as a reminder to practitioners who are prescribing it that any suspected adverse events should be reported to the TGA, so they can build a picture around what adverse events are associated with the new indication for prescribing the drug. Next slide, please, Sam. And a reminder, obviously, that the use of cyclosporin in dry eye disease is not a particularly new thing. Most of you will be familiar with the latest reports out of the JEWS 2 workshop. I'm just showing an isolated selection of the images from those papers, just reminding you that as part of our diagnostic and management protocol for dry eye disease, when you have diagnosed your dry eye as sort of mild to moderate or above, there's a recommendation that we look at step 2 interventions there in the table to the left there, and one of those obviously are the corticosteroids that we use frequently to get inflammation under control in dry eye, and you'll see cyclosporin mentioned there as well. So obviously well documented for the use in dry eye, and that's our main indication now for the use of the preparation. Next slide, please, Sam. So the next data I'm going to show you really talk about how cyclosporin works in controlling dry eye disease, and gives you a little flavour for how effective it is. And most of that information is taken from the Cochrane review, the systematic review that you see in front of you there. Next slide, please, Sam. Okay, so we have a representation on the right-hand side of what's known as the vicious circle of dry eye disease, how the inflammation kicks off, causes damage to the ocular surface, and this becomes a cyclic problem on the dry eye. Getting that inflammation under control is the absolute key. So you're effectively putting a break in that circle to allow your other therapeutic interventions for dry eye, whether it be tear supplements or other interventions, for them to give them the best chance of managing the patient's signs and symptoms. So obviously breaking the inflammation of vital importance. I've put a couple of red rings around the areas in that vicious cycle that we believe cyclosporin acts in controlling dry eye. Certainly it prevents cytokine release and MMP activation on the ocular surface, so theoretically it will manage the ocular surface inflammation you see in dry eye. And whether indirectly or directly, there's not a lot of information about that, but it's hard to imagine that topical administration of cyclosporin to the ocular surface will get in any great concentration into the lacrimal gland. So it's thought there's probably an indirect effect on improving secretion of the tears from the lacrimal gland, but all of that's relatively uncertain. So you can see how it's thought to work and probably how it does work, but the systematic reviews that I showed you on the previous slide are relatively cautious in advocating the use of cyclosporin in dry eye disease. It's largely due to inconsistencies and design deficiencies in the trials that were assessed. There are around 18 or 20 good quality trials out there, but all of them have certain deficiencies and they're all very different to each other. But variously, those trials did report that there were improved symptoms, reduced corneal staining, improved impression cytology from the conjunctiva, and that the Schirmer and tear breakup time metrics were all improved as well. They also did indicate that the use of cyclosporin brings with it significant ocular surface stinging and burning as a side effect. Next slide, please, Sam. So the side effects are documented in these two tables here. Again, a little bit small for you to see. But I want to make a couple of points from this slide. Most studies do show that that burning on installation and conjunctival hyperemia are relatively common in the use of cyclosporin regardless of the concentration used. The slide on the right-hand side, which you won't be able to see too well, effectively describes a study that puts cyclosporin 0.1% in, so roughly the same concentration of Cequa, either 4 times a day on the left, twice a day in the middle, or just use the vehicle component on the right-hand side. And for many of those adverse events, you'll probably notice that the problems with the 4 times a day administration of cyclosporin A weren't significantly worse than those with the vehicle themselves. So the message from this is largely or many of the adverse events that you see with cyclosporin use are probably related to the vehicle, but it's likely also, if you look at this data, that the drug itself is responsible for the burning on installation and potentially some of the conjunctival hyperemia we see as well. However, I think it's important to point out that the side effects that we see in ocular administration are apparently on the milder side, particularly for Cequa, and certainly not the level of problems that you can see in terms of side effects systemically when cyclosporin is administered. Next slide, please, Sam. So I put this slide in just to remind you of the sort of information that used to drive optometric and ophthalmologic decision-making in using cyclosporin. Because it wasn't available commercially until now, optometrists, if they wanted to prescribe it, had to have it compounded. On the right-hand side there, I'm just showing a figure from a sheet that was sent to me by Slade Pharmacy showing the preparations of cyclosporin they made up, the different concentrations and the cost to the patient. Remember, it's not available on the PBS. If you do prescribe it at the moment, your patient will have to pay full cost for it. If you do have it compounded, that will cost them more, presumably, than purchasing the proprietary preparation from the pharmacy. And it's probably worth pointing out that clinical trials have used cyclosporin anything from 0.05% up to 2%, and they've used it in administration anytime from 1 times to 4 times a day. And the general message coming out of those trials is that for any of those concentrations or any of those degrees of administration, topical use of cyclosporin is relatively safe, with relatively few either systemic or ocular surface side effects aside from those that I've talked about on the previous slide. And there is potentially a little suggestion that the type of vehicle used in the Cequa preparation is perhaps a little bit kinder on the ocular surface. So it's quite well tolerated compared to some of the other preparations. Next slide, please, Sam. Okay, so this table taken from a recent publication shows you some of the preparations of cyclosporin that have been available to eye care professionals around the world. You'll see Restasis there, which has been around for a while. You'll see Cequa mentioned there, which is the one that's now approved for use in Australia. And you'll see a range of other preparations at different concentrations as well. You'll see that by this stage, somewhere between 0.05% and 0.1% cyclosporin seems to be the preferred concentration for the proprietary preparations, and again can be used anytime, anywhere between 1 and 4 times a day. Probably worth pointing out that cyclosporin is very poorly soluble in aqueous vehicles, but it's very well soluble in lipids, so it's highly lipophilic. And so the vehicle that Cequa is in is made up of these little lipid bubbles called micelles, which actually wrap the cyclosporin up and improve its solubility in the vehicle. So that's one of the reasons that you'll see that most cyclosporin vehicles have an oily element to them. Next slide, please, Sam. So just to wrap up the little bit of chat that we've had about the use of cyclosporin in dry eye disease, in conclusion, Cequa's can be used twice a day, safe and effectively in the management of moderate dry eye disease. It's also safe 4 times a day, but if you use it twice a day, it'd be considered on-label by the TGA. If you use it 4 times a day, it's considered off-label use. But just remember, the systematic views remain relatively equivocal about the benefits of cyclosporin in dry eye disease, despite the fact we have access to prescribe it. It's relatively effective in most studies for ocular surface inflammation and for managing the lacrimal gland related signs. Obviously, its effect on direct effect on T cells can improve the reduce the inflammation in the lacrimal gland and improve secretion. So I would just make the point that where surface inflammation is your primary concern, then probably a short course of topical steroids is the thing you should start with, should be preferred over cyclosporin. There's certainly no evidence that your cyclosporin would be more effective than a course of topical steroids to try and break that vicious cycle in the first degree. But you should also remember that where tear productions are concerned for you, then it may be appropriate to consider and add CEQA as well, or cyclosporin as well. I'd suggest that CEQA is probably best considered after you've used a short course of steroids, where the inflammation needs a longer term control, because it actually, the trials actually suggest that CEQA is safer in the longer term, certainly up to 1 to 4 months and maybe beyond that. TGA approval doesn't say anything about the length of time you prescribe CEQA for. It only requires that you review its efficacy every 6 months or so. So CEQA is probably safer to use for the patient in the longer term once you've got the inflammation under control with a short course of steroids. And of course, CEQA is a viable alternative in situations where you can't prescribe topical steroids. Next slide, please, Sam. So what about off-label uses beyond the administration of CEQA more frequently than twice a day in dry eye disease? Well, I've listed all of the conditions that cyclosporin has been trialled in there. And just to cut a long story short, use of cyclosporin in the management of ocular allergy has been the most promising application of it. So that represents perhaps our most viable off-label use for CEQA when we finally get access to it in Australia. And the experimental concentrations in those trials that I've referred to there have typically been on the high side, somewhere between 1 and 2% with the frequency of administration up to 4 times a day. Next slide, please, Sam. So here's a little snapshot of a randomized controlled clinical trial that was carried out using 0.1% cyclosporin A, so very approximately the concentration of CEQA. It was in an emulsion style vehicle, more consistent with what you would see in the Restasis, and it was administered either twice a day or 4 times a day. The slides I've shown you here are kind of a composite efficacy estimation of how VKC responded to cyclosporin. It's a composite of a range of different signs and symptoms involving photophobia, tearing, itching, mucus discharge. So they measured all of these things and then created this index. And effectively what those slides are showing you is that cyclosporin is more effective across a range of signs of symptoms in VKC than the vehicle, which was the control on the right-hand side there. And although there wasn't that much difference between the twice a day or the 4 times a day administration, the 4 times a day administration was slightly more effective. Certainly when you broke it down to the individual signs and symptoms, the 4 times a day administration was significantly more effective than the vehicle itself for all of the metrics looked at, whereas twice a day administration was significantly more effective against the itching, but not necessarily for the other components. So I guess the message here is that twice a day administration of cyclosporin for VKC can be effective in managing the condition, but 4 times a day is perhaps going to be more effective. And the efficacy seems to hold regardless of age, gender, or the form or type of VKC as well. Next slide, please, Sam. So just very quickly to conclude, in a nutshell, what that trial is telling us is that the VECTIS trial, which was the VKC trial, says CYC is beneficial for the management of VKC. Twice a day administration would give some relief, but 4 times a day is the most effective way to administer it. Either way would be considered off-label, obviously, in our situation. And you probably need to use your cyclosporin over a period of months for the most effective outcome, because obviously the VECTIS trial was over a period of months as well. Just a slight caveat, as Ereeny pointed out earlier on, contact lens related papillary conjunctivitis is a slightly different mechanism to the other ocular allergies, or most of the other ocular allergies. So cyclosporin A is going to be less effective in the management of that and probably not indicated. So if you're thinking of using cyclosporin because you need a longer term management of inflammation in one of the ocular allergies, CLPC wouldn't be one of the indications, but the others may be. Okay, certainly again, the advice I would give is that a short course of steroids are probably indicated for allergy exacerbations prior to considering the use of CEQA, but it's certainly a good alternative where longer term management is required or steroids are ineffective. And can I have the last slide, please, Sam? So just to sum up, cyclosporin in the form of CEQA is safe and equivocally effective for on-label use in management of dry eye disease, and off-label, of course, as well in dry eye disease, and off-label use in the management of certain allergic eye diseases as well, probably very effective there as well. It's been proven safe in the clinical trials, but just remember to tell your patients that it's likely to sting on installation and may make their eye a little bit red at times. Not everyone experiences that, but a small proportion of individuals do. Just remember, the vehicle is probably a contributory factor here as much as the medication itself. Please remember that cyclosporin's got its main value in situations where the T cells are primarily driving inflammation. It's also obviously good in a situation where steroids can't be used for some reason, or where steroids have proven ineffective, and also something to be considered where inflammation control is required in the longer term, and particularly as is indicated on the TGA approvals, particularly where you're looking to stimulate tear production as much as manage the surface inflammation. And just remember that when you do start using CEQA, it'll spend 5 years on the Black Triangle scheme. So that'll mean that you guys have to carefully report on any adverse events you come across during CEQA use. So thank you very much indeed for your attention. Thank you, Sam.
Thank you, Alex. That was just wonderful. So we've had a few questions come through from the audience already. So the first one is, what is the recommended dosage of short-term steroids for ocular surface inflammation prior to using cyclosporin?
So I would suggest that 4 times a day would be the minimum, but you can go, 6 times a day, 8 times a day. Pulse dose is entirely acceptable as initial indication. I would suggest that most optometrists who are using steroids to manage inflammation in dry eye typically go 4 to 6 times a day, and probably use it for a course of 7 days to 10 days, followed by a short taper period. Hopefully that deals with your question.
I think that's good. And how often should we follow up a patient after we've prescribed cyclosporin?
Well, I would suggest that you would follow them up probably in a couple of weeks to begin with. This is not one of those things that you need to look at the next day or the end of the week. So probably once you've started prescribing, a couple of weeks would be the earliest thing. As I've said earlier on in one of those slides, you will find that cyclosporin takes a little while for its effect to take hold. So at that 2-week review period, you wouldn't necessarily be expecting the patient to show a massive improvement, but they may show some improvement. Certainly that's what the clinical trials suggest.
Okay, thanks, Alex. And just one more from me before we head off to the next presenter. Which inflammatory markers did the studies focus on when they were looking at improvement?
Are we talking about the VKC studies?
I believe so.
So my understanding is that they haven't particularly looked at biomarkers of VKC. The signs of inflammation they were looking at gradings of redness, damage to the ocular surface in terms of staining. So they were grading staining and things like that as well. So the study I showed you there didn't particularly look at biomarkers, if I'm correct, but I believe there may be some other studies of ocular allergy that did look at some of the biomarkers of ocular allergy. I just don't have them at the front of my mind, sorry.
No, that's okay. You've done a wonderful job tonight, so thank you again.
That's my pleasure, and thanks for inviting me.
All right, perfect. All right, so it's now time to move on to our next exciting presenter, which will be Natalie Watt. Natalie is a therapeutically endorsed optometrist who graduated from the University of Melbourne in 1996. Her career began in public health optometry at the Australian College of Optometry, which we know as the ACO. Natalie then entered private practice in Keilor, Victoria, where she worked for 15 years practicing full scope optometry. However, her interest in public health and eye care drew her back to ACO in 2016 before she accepted a position at Deakin University as an associate lecturer in optometric clinical skills in 2018. Welcome, Natalie. I'd like to now pass it over to you. She's going to be giving us a presentation on the therapeutic diagnosis of common pupil disorders.
Great, thank you so much, Zara, and good evening, everyone, and welcome. So if I could just have my next slide, please. Beautiful. So the learning objectives of this presentation is just to provide you all with some revision around how to approach the workup of anisocoria and to revise the abnormal pupil responses associated with Horner syndrome, 80s tonic pupils and Argyle-Robinson pupils, and just to revise pharmacological testing associated with Horner syndrome and 80s tonic pupils. So what I might actually do is just take a quick poll if we can. Sam, if you could put that first poll up for me about everyone's knowledge on pharmacological testing for abnormal pupil responses. Beautiful, excellent. So if we just might sort of engage everyone for a couple of minutes, if you can just sort of answer this question, that would be great, and then I can get a feel for how you actually rate your knowledge for testing abnormal pupil responses. So Sam, you'll need to give me an indication of when that's ready to sort of, great, thank you so much. Excellent, beautiful. Okay, so most of you have some sort of knowledge around how you would actually pharmacological test for abnormal pupil responses. That's great, beautiful. All right, can I have my next slide, please, there, Sam? I can move, yep, great, excellent. So we're all pretty much aware of the definition of anisocoria being a difference in the size of the pupils, and that this may be caused by a dysfunction of the sympathetic or parasympathetic pathway, but as a rule it's never really caused by an afferent pathway lesion unless that lesion is actually also affecting the parasympathetic or sympathetic pathway. So moving on to the next slide, beautiful. So this is just a bit of a fun fact for you all. So these are just a couple of celebrities who actually do have anisocoria. So the person on your left is a famous British singer-songwriter, David Bowie. So he actually acquired his anisocoria when he was a teenager through having a fist fight with one of his best friends, funny enough, over a girl. And Mila Kunis, who is a famous American actress, she has Fuchs heterochromic iridocyclitis, so a chronic uveitis, which contributes to anisocoria through atrophy of the iris sphincter. So just moving on to the next slide. Excellent. So, you know, you see anisocoria in your patients, so what do you do? So the first thing you probably want to do is ask your patient about how long they've actually had, or try and figure out how long they've actually had that anisocoria for. And one of the simplest ways to actually do this is via the photo album test. So you can actually ask your patient to bring in some old photos, and then you can establish just how long that anisocoria has been there for. You can also look for iris heterochromia, so that can be associated with congenital Horner's, giving you another sort of indication of whether it's been long-standing. So this is quite important because a long-standing anisocoria is probably not going to concern us too much, but an acute presentation could be due to some serious underlying pathology. So then you need to determine which eye is affected. So is it a failure of the pupil to dilate, or is it a failure of the pupil to constrict? And again, we can really do a simple test to figure this out. So you can just assess the pupils in bright and dim illumination. So if we have physiological anisocoria, you're probably going to have normal light, well, you will have normal light and near response. And with a pathological anisocoria, you'll have an abnormal light and or near response. So moving on to the next slide. All right, so when you're trying to determine your differential diagnosis, I think it's actually easier to break this down into 3 sections. So first section being anisocoria with normally reactive pupils. So that would include physiological anisocoria and Horner's syndrome. In your second section, you've got anisocoria with one pupil that is poorly reactive or non-reactive to light, which includes your iris sphincter damage, so trauma to the eye, pharmacologic blockade, so someone who might be taking topical atropine, 80s tonic pupil, third nerve palsy, and your intermittent unilateral pupillary mydriasis. So that's just where one pupil transiently dilates and is poorly reactive to light through conditions such as migraine. And then you've got both pupils non-reactive to light, which includes Argyll-Robinson pupil. So the 4 conditions that are highlighted there are the ones that we're going to focus on during this talk. Just moving on to the next slide. Yep, and just keep going. Great, thank you. So let's focus on physiological anisocoria first. So typically your patients will be asymptomatic and they'll present with this at birth. It's relatively common, so roughly around 15 to 20% of normal people will have anisocoria. So if you're seeing roughly 10 patients a day in your practice, you should be documenting at least 2 of those as having physiological anisocoria. So it might be very obvious or it could be very subtle, and it can change in size and sides. So it'll have normal sort of light near reflexes, and typically the difference between the eyes is roughly around, it's less than 1 mil, and that usually won't change in bright or dim light. Now, because this is fairly benign, we don't usually need to do any pharmacological testing or other investigations. Just moving on to the next slide. And again. All right, so let's focus on Horner's syndrome. So it results from damage to the oculosympathetic pathway. This can be quite a serious finding because it can be caused by lesions that have significant sort of morbidity and mortality associated with them. Just moving on to the next slide. All right, so the sympathetic pathway is quite a long one. So you can find that you can have damage along any of those 3 neurons that are associated with the sympathetic pathway. And these are just a list of some of the causes that can cause a Horner's syndrome. So you're looking at sort of if you have a central defect, a brainstem stroke or tumour. You have a spinal cord tumour possibly causing a Horner's syndrome, and cervical spondylosis, so just wear and tear of the spine. For a preganglionic sort of lesion, you can get a tumour that is found on the apex of the lung, which is called Pancoast tumour. Your internal carotid artery dissection, so you're just going to get a tear in the inner wall of the artery. Then your blood will actually fill the vessel wall and cause it to enlarge and then cause compression of the neuron. And then you've got the, you could have, damage from neck or chest surgery. For your postganglionic neuron, you can have causes such as internal carotid artery dissection again, a cavernous sinus tumour, cluster headache, or again, any neck surgery can cause Horner's syndrome to develop in that 3rd order neuron. Okay, so moving on to the next slide. Beautiful. All right, so in terms of signs with the Horner syndrome, these signs typically will occur on the same side of the lesion within the sympathetic pathway. So you'll tend to see a myotic pupil, as there's a dysfunction of the dilator muscle as the sympathetic pathway has been affected. So the anisocoria is going to be more prominent in the dark because you have that dilator problem. There'll be a dilation lag. So what that means is when you dim the lights, you'll probably find the anisocoria is at its greatest within that first 10 seconds. And then the Horner's pupil will start to dilate sort of possibly around that 10, sort of 15-second mark. Your pupils are going to be normally reactive to light because your iris sphincter functions normally. In terms of eyelids, because the Mueller's muscle is innervated by the sympathetic pathway, you'll get this upper eyelid ptosis. Typically, it's roughly around the 1 to 2 millimeters, but it can be up to sort of 3 millimeters. You can also get an upside down ptosis. So this is where the lower lid's slightly raised, and that will cause the palpebral aperture to be narrowed and giving that illusion of an apparent enophthalmos. So moving on to the next slide. You can also get some extraocular muscle involvement, so you can get a muscle paresis, especially if the lesions are affecting the brainstem or cavernous sinus. You can also see iris heterochromia, and this is typically seen in children with congenital Horner's, but it also can develop in children that acquire the Horner syndrome younger than 2. You can also see it in adults who have had this long-standing as well. Moving on to the next slide. You can also have some neurological signs, so any sensory or motor abnormalities in the form of pain and weakness in the arm. Anhidrosis, so that typically occurs with the central or preganglionic lesion. So you can get absence of sort of facial sweating on the same side of the myotic pupil. And Harlequin sign, which is an impaired sort of hemifacial flushing, more so seen in children, but it can be seen in adults. Just moving on to the next slide. All right, so this slide is really just to give you some revision on your pharmacology knowledge. So we all know that noradrenaline is a neurotransmitter that's released by the postganglionic neuron, and then that causes the dilator muscle to react. So if we have a problem with that postganglionic neuron, we're going to get an upregulation of the alpha adrenergic receptors on the dilator muscle, and this can often take sometimes a couple of weeks to actually occur. So if we use a really small amount of diluted alpha agonist, you're going to find that your pupil will dilate because those receptors are hypersensitive, but in a normal pupil you will not get a response. Moving, yeah, great. Yeah, move on. Thanks, Sam. All right, so in terms of diagnosis, there are a couple of different pharmacological agents we can look at. So there's topical cocaine and topical aproclonidine. Now, topical cocaine, we don't have access to this in Australia, and essentially its mechanism of action is to block the reuptake of noradrenaline from the synaptic cleft. So if you have an intact neuron, the cocaine will actually cause a dilation effect because basically you've got an abundance of neurotransmitters floating around in that synaptic cleft that will cause that dilation effect. However, if you've got a Horner's pupil, your sympathetic pathway is not going to be intact, so therefore you're not going to have the neurotransmitter being released from that postganglionic neuron, so therefore the pupil is going to fail to dilate. So topical aproclonidine, you are all probably pretty familiar with this as being an anti-glaucoma drug. So it has quite a strong alpha-2 agonist effect, but it also has a very weak alpha-1 agonist effect. So in a normal pupil, you won't see a dilation if you use this particular drug, but with a Horner's pupil, you will, just due to that increased receptor sensitivity. You need to sort of watch the actual pupils for about 40 minutes before you might see a reaction. And just a word of caution, you probably shouldn't use this in children just because of the side effects of lethargy and bradycardia. Okay, so moving on to the next slide. Great. So you've diagnosed your Horner syndrome, and then you really want to figure out or try and localize the lesion along that sympathetic pathway. So we can use dilated phenylephrine, 0.25%. You can use anywhere also between sort of 0.125 and 1% phenyl, but typically we look at using 0.25%. So you use a 110 dilution factor of 2.5% phenyl with saline. So that means you'll do 1 drop of phenyl to 9 drops of saline just to produce that 0.25% solution. You'll then instill that drop into both eyes. And the idea is that if you have a central defect, then a really small dose or concentration of phenylephrine really is not going to have any effect on the dilated muscle because the receptors are not as upregulated. However, if we've got a peripheral defect or a postganglionic lesion, then those alpha-1 receptors are going to be hypersensitive and upregulated, so that low concentration of phenylephrine will cause a dilation. Just moving on to the next slide. So this is a nice little table giving you a summary of the pharmacological testing for Horner syndrome. I haven't spoken or discussed hydroxyamphetamine. Its mechanism of action is really just to push the noradrenaline out of the postganglionic neuron. And if you've got a normal pupil, you'll get a dilation response. If you have a central or preganglionic sort of a lesion, you'll get a dilation response. But with a postganglionic problem, there'll be no change. Okay, just moving on to the next slide. So in terms of management, so you've diagnosed your Horner syndrome and you've localized it. If they're young, you really probably do want to refer these pretty urgently to an ophthalmologist just to rule out any serious underlying systemic conditions. Most causes are from sort of injury to the neck or shoulders during birth, and also at birth there can be a defect in some patients or some young children of the aorta, but it can also be from a tumour, typically neuroblastoma. So if it's been long-standing because you're seeing iris heterochromia or your photo album test has indicated that it's long-standing, you really don't need to be concerned too much about these, and you can just review them at your normal regular optometric consultations. If, however, you've got a first or second order lesion, then I'd probably refer these off fairly quickly again, just because there can be that associated sort of underlying pathology there that can be quite serious. All right, just moving on to the next slide. All right, so let's now talk about Adie's tonic pupil. So this is typically associated with a dysfunction with the parasympathetic pathway. So you'll find that there'll be a sort of denervation to the parasympathetic pathway supply to the iris sphincter and ciliary muscle, and it's typically sort of the sort of dysfunction occurs around at the sort of ciliary ganglion, and then that causes a dilated pupil to occur, and then they come in or possibly come in with symptoms of photophobia because of that dilated pupil. And because the ciliary muscle is actually involved, you'll get some near blur due to that accommodative dysfunction and or sort of brow ache or headache. Just moving on to the next slide, please, Sam. All right, so the signs that you'll actually see with an Adie's tonic pupil, like I said, you'll have a dilated pupil, and it typically has sort of sluggish or no reaction to light. And then if you actually give your patient a near target to fixate on, they will sort of have this sort of slow constriction at near to that target. And then when you ask them to fixate into the distance, you'll get a slow redilation of that pupil again. So most of these Adie's tonic pupils have a sectorial sort of iris paralysis, so about 90% of them. And in that area of paralysis, you'll actually see the iris appear quite flat and thin. You can also get this sectorial iris streaming effect, which just basically refers to the appearance of the iris sort of moving a little bit like an earthworm, or has this worm-like movement. And it's pretty much just created from, you know, having parts of the iris being paralysed and then other parts of the iris constricting. All right, just moving on to the next slide. All right, so the pupil might actually be fixed for the first sort of 2 to 4 weeks, even to the installation of pilocarpine, but over time that pupil just may actually may become smaller, and there's a saying it's called little old Addie's pupil. In terms of the epidemiology, the prevalence is roughly around sort of 2 in 1,000 people that you'll actually see this particular condition. It's typically females aged between 20 and 40 years of age. It can happen in males, but they are typically a little bit older than that. Most of the time you'll find that it is a unilateral presentation, but 10% can be bilateral. And of those unilateral presentations, after sort of around 8 to 10 years, 50% of them will become bilateral. Okay, just moving on. Thank you, Sam. So like I said earlier, typically you'll get damage to the parasympathetic pathway at the ciliary ganglion level. Most causes are idiopathic. But it can also be caused by several other conditions such as these listed here. So your viral infection, trauma, migraine, ocular surgery, tumours, diabetes, MS, or stroke. All right, again, this is just a really quick slide to revise your pharmacology knowledge of the parasympathetic pathway neurotransmitters. So acetylcholine is actually released by your postganglionic neuron, causing the sphincter muscle to constrict. So if we have a problem or damage to the postganglionic neuron, then you're going to get an upregulation of the muscarinic receptors on the iris sphincter. And again, this can take a couple of weeks to occur. So what we're going to do from a pharmacological sort of point of view, we're going to use a small amount of diluted cholinergic agonist, and that is a typo. That should actually say constriction. So it will actually cause a constriction on the sphincter that has those hypersensitive receptors, but in a normal pupil there will be no response. So next slide, please. So the drug of choice is pilocarpine, 0.1%. So what we're going to do is use a 1 to 10 dilution factor of 1% pilocarpine. So it'll be 1 drop of 1% pilocarpine to 9 drops saline. And then what you will actually do is place a drop of that diluted pilocarpine into each eye. Again, wait your sort of 45 minutes and then assess if there's been any sort of reaction to the installation of pilocarpine. So with a tonic pupil, you'll see constriction, and with a normal pupil, it will not constrict. Okay, so moving, great. So I think this is just a nice little sort of figure that shows you how we can use pilocarpine to work through our differentials. So if you've got a dilated pupil and you use a weak concentration of pilocarpine, then that could suggest that you have, and there's a response that could suggest that you have an 80s tonic pupil. If there's no response, then you can use a stronger dose of pilocarpine, and if you get a reaction, then it could be a third nerve palsy. And then again, if there was no response, it could actually be due to pharmacological blockade, so patients using atropine. So moving on to the next slide. All right, I'm hoping that this actually works because we've had some trouble with the lag when we've played it. So it's just a slide showing you 80s tonic pupil. So hopefully it works okay. If you can play that for me, Sam. So it's just going to give you firstly show you the reaction to light. So left eye, it is a little bit laggy, but you'll sort of get the gist of what's going on. Left eye is normal. And then we go across to the right eye that has the 80s tonic pupil, and you can see that there's very little sort of movement. It's quite sluggish. You're just going to need to wait a little bit. It gets to about the 50-second mark, and then they'll instill pilocarpine, but you can just see that that light's really not causing much reaction to their pupil. So a couple more seconds and you'll see that they'll instill that pilocarpine. All right, so after the installation of 0.125% pilocarpine, you'll see that this is the left eye, really no change in pupil size. And then the right eye, we've got a constriction due to the hypersensitivity of the receptors. Okay, so let's move on to the next slide. So in terms of management, you really want to err on the side of caution with these particular patients because they can be associated with some serious underlying pathology. However, if you are 100% sure that it's absolutely benign, there is really no need to refer, and you can just offer your patient some supportive treatment. So that could be in the form of sunglasses for glare control, giving them a pair of glasses for near to help with their accommodative dysfunction. Rarely pilocarpine is prescribed. I've never seen it done. It's possible, but I've actually never heard of anyone actually doing it. And you can just review them monthly in the early stages just to monitor that accommodative dysfunction. But this usually does resolve over time, so usually months, but sometimes it can take years. So moving on to the next slide. All right, so last condition, we've got Argyll-Robinson pupils. So I think this is a really nice mnemonic to try and remember some of the signs associated with Argyll-Robinson pupils. So ARP, accommodation reflex present, and then you've got in the reverse order, PRA, pupillary reflex absent. Just moving on to the next slide, beautiful. So the signs you're going to find with an Argyll-Robinson pupil is that they're going to typically have normal vision, but they'll have bilaterally sort of small and irregular pupils. They'll have a light near dissociation. So what that actually means is that their pupils are going to really, they don't react very well to bright light, but then when you give them a near target to look at, they'll constrict quite briskly with accommodation, and then when you actually get them to look into the distance again, there'll be a brisk redilation. They don't dilate very well, like 100% in dim light, and you'll find that there'll be some iris atrophy with transillumination. Great, so this is just our last video for tonight. Again, hopefully it's not too laggy for you all, but it's a really good demonstration of the light near dissociation if you've actually never seen it. So if we can play that, please, that would be great. So we're looking at, you know, the reaction to light, which is really not much. So it's quite poor, no reaction going on. And then you'll actually see the patient will be given something to fixate on it near, and you'll start to see those pupils briskly constrict. Thank you. Okay, so next slide. All right, so causes of Argyll-Robinson pupil. So it's thought to be caused by bilateral damage at the level of the pretectal nuclei in the midbrain, so therefore it's affecting the parasympathetic pathway. It's a highly specific sign of late neurosyphilis. That's very, very rare though. And other causes can be MS, stroke, diabetic neuropathy, chronic alcoholism, and herpes zoster. So we don't tend to, you know, investigate this with pharmacological testing. We tend to refer these patients off to an ophthalmologist to really just find the underlying cause of their pupil abnormalities. Okay, so next slide. All right, so this is the last slide. I'm not going to go through this in detail just because it probably is a little hard for you to see. The writing's actually quite small, but it's actually a really nice little algorithm for practitioners to use in a clinical setting to help aid them in their diagnosis of anisocoria. So I think these slides are going to be made available to you after this webinar tonight. So you'll be able to go through this in your own time if you actually you do have a patient with anisocoria, and then try and figure out your diagnosis. So thank you for all attending.
Okay, thank you for that amazing presentation, Adley. So audience, if you have any questions, we're going to give you some time now to enter them. And just to remind you, if time does not allow, which I think this is the case, Natalie's going to be able to answer your questions by the end of the session. And even if that's not enough time, the questions will be answered and all of the answers will be posted on our online pages. So do not worry at all. Okay, so now we'll move on to Amanda, who's going to present our next presenter.
So our final presenter for the night is Dr. Simon Backhouse. For those who do not know, Simon Backhouse is a senior lecturer in vision science at the School of Medicine at Deakin University. He graduated with a Bachelor of Optometry, first class honours, from the University of Auckland in 2003 and was awarded Therapeutic Prescribing Authorisation in 2009, in the same year where he completed his PhD in Optometry at the University of Auckland. He was a New Zealand Association of Optometry Education and Research Fund postdoctoral research fellow from 2010 to 2012, and he's worked part-time as a registered optometrist in New Zealand from 2004 to 2014, and had a variety of teaching roles at the University of Auckland until he moved to Deakin University in 2014. He was a founding member of a myopia control clinic at the University of Auckland in 2010. Simon has also authored a number of peer-reviewed research publications and conference presentations. So I'd like to hand it over to Simon as our final presenter tonight, who's going to give us an update on research regarding the use of atropine to control myopia.
Great, thank you very much, Amanda, and good evening, everyone. Thank you for sticking with us. Next slide, please, Sam. So as Amanda said, we'll be going through looking at low-dose atropine, and a lot of the first part of this will probably be quite familiar to you. But in the last year or two, there's been a lot of interesting research coming out as to what the most efficacious dosage of atropine is, and potentially the 0.01% that people have been prescribing is not really doing what we think it is meant to be doing. So next slide, please, Sam. So as I'm sure we're all aware, the origin of the majority of human myopia is axial in nature, and the whole eye, in fact, is actually expanding. And you can see that in these MRI images and the colored images in the middle there, that we get axial elongation, but you also get expansion in both the vertical and horizontal directions. And we can see that in the figure on the right. The top shows that we've got a really good correlation between eye length and increasing refractive error. So as we become more myopic, the eye gets longer. But we also have weaker correlations between both the height of the eye as well as the width of the eye with increasing myopia. So what we see is that majority of the expansion is axial, but we do get this overall increase in the size of the eye. Every diopter of myopia that we get is approximately associated with about 0.35 millimeters of axial elongation. Now, this axial elongation is what leads to some of the pathology that we see associated with myopia. So next slide, please, Sam. So why do we want to control myopia? Why can't we just keep prescribing contact lenses and spectacles to our patients with myopia? As I just mentioned, as the eye gets bigger, it puts strain on the eye, and the retina on the inner layer of the eye is not designed to stretch. And so what we see is as that eye continues to expand in all directions, but particularly axial in nature, we end up with myopic maculopathy and an increased risk of retinal detachment. And we can see that in the left-hand figures there, that as we increase the level of our myopia, we're going from low to moderate to higher levels of myopia, the odds ratio of developing myopic maculopathy and retinal detachment significantly increases. You can see that below 5 diopters, so in that low to moderate myopia, about 0.4% of our myopic patients will develop a myopic maculopathy. Above 5 diopters, around about 25% of our patients will go on at some point in their life to develop a myopic maculopathy. So for these high myopic patients, this is a really large proportion who are going to have this myopic degeneration that can lead to irreversible blindness. So if we can stop and prevent that 25% of patients from actually developing the high myopia in the first place, we can really prevent the myopic maculopathy from occurring and significantly reduce the risk. The same applies to retinal detachment, but we also have posterior subcapsular cataract and glaucoma risks that, while the odds of developing those with higher myopia are less than the myopic maculopathy or retinal degeneration and detachment, they still have an increased risk of developing it. And again, it's linked to the level of myopia. The higher the myopia they have, the more risk they have of developing these. Now down the bottom right, I've got some other statistics just for comparison. And you can see particularly interesting with cardiovascular risk, so the risk of developing a stroke. If you're smoking more than 20 cigarettes per day, the odds of having a stroke are 2.9 times higher than if you weren't a smoker. So what we can see is that this is a really strong public health initiative to try and get people to reduce their smoking, so we stop the risk of having a stroke. There's also a similar sort of risk with high blood pressure and stroke, and high blood pressure and having a heart attack. But we're only looking around 2 to 3 times the increased risk with high blood pressure or with smoking for stroke and heart attack than if you didn't have those factors. But we have this really strong public health push to prevent people from having these. You look at the myopic maculopathy and the retinal detachment risks, and those low numbers at 2 to 3 is only happening in our low myopes. We get into our high myopes, we're 200-300 times more likely to have myopic maculopathy, or 50 times more likely to have a retinal detachment than if we didn't have that high myopia. And yet there's not a public outcry about the myopic individuals. And so it's our job as primary healthcare providers to really start educating the public that no amount of myopia is safe, that there is an increased risk of developing these other pathological diseases, regardless of the level of myopia that we have. So next slide, please. So our justification for myopia control then is if all myopia is associated with an increased risk of morbidity, and we've just seen in the odds ratios in the previous slide that regardless of even if you're a low myope, you still have an increased risk of developing those comorbidities. So if myopia is associated with this increased risk, but we can actually modify myopia to reduce that risk and reduce the amount of myopia, through both reducing the number of myopes, so reducing the incidence, as well as reducing the degree of myopia for those who actually develop it, so reducing the progression, then we can expect to reduce the morbidity in the population. So by having fewer people in those higher levels of myopia, we have fewer of those comorbidities being expressed. So less myopic macular degeneration, less retinal detachment. So that's the aim and the justification for myopia control, is not necessarily at this point in time with what we've got stopping myopia entirely, but trying to rein it in and keep it in those lower levels of myopia. So we can see in the figure here that this is a theoretical patient where we've got someone who starts, and at about the age of 8, they suddenly start falling off that myopic cliff. They start progressing and they end up coming out at about 6 diopters of myopia. Now, our intervention occurs around that sort of 9 years of age when they first develop that sort of first 1.5 diopters of myopia. We intervene, we slow the rate of myopia development. We're not stopping it entirely, but we're slowing that rate of development. And we see that we end up with this patient coming out at somewhere like 2 to 3 diopters of myopia rather than the 6 that they would have ended up at. By keeping them in that lower bracket of myopia, we've significantly reduced the risk of morbidity from having that myopic refraction. Now, it's been predicted that if we can reduce the myopia in a patient by as little as 33%, so slow it down only by a third. So instead of progressing at 3/4 of a diopter in a year, they're progressing at only half a diopter in a year. We'd reduce the number of people that go on to develop high myopia, so myopia above 5 diopters, by 73%. So 73% less people would end up in that really high risk category for the comorbidities. If we can instead reduce the myopia progression by 50%, so we're halving the rate of progression per year, then we've got a reduction of 90% of the people who go on to develop high myopia. So even very small amounts of myopia control are going to have quite significant effects in terms of reducing high myopia and thus reducing the amount of morbidity that our patients have. Next slide, please. So one of the things that's been trialled for controlling myopia is atropine. And so this came from the well-established correlation between near work and myopia. So the more near work people do, the more likely they are to be myopic. And this has been known for centuries. So the early, well, in the late 70s, they decided that, well, if people are doing a lot of near work and developing myopia, there's potentially a link there with accommodation. And so atropine, being a cycloplegic, was trialed to try and knock out the accommodative system and see whether we could control myopia by doing so. And you can see in this figure at the bottom that indeed atropine did work. That in the treated eye in the first year, we have a much lower progression rate. In fact, it actually has a reduction in progression and it goes in the opposite direction, whereas the control eye continues to progress the same as it was doing in the pre-treatment. You cross that trial over, and so you put the atropine in the eye that wasn't being treated, and you get a reversal of the effect. And the eye that had atropine in it initially continues to progress at that original rate. And eventually, once the patient has stopped progressing entirely, we've slowed them down, and we've reached that adolescent age where their myopia is no longer progressing, and we've slowed effectively the rate of development. So this is great. We can see that we use atropine, we're able to slow the progression of myopia. But this atropine use was typically around 1% atropine, which is what we have available to us as optometrists on the PBS, albeit off-label. So people started looking at this and wanted to see how the atropine was actually affecting it. And we can see in these figures on the right that this is where we're having a look at giving atropine injections into a chick eye that's been form deprived, where we're inducing myopia. And what you can see is that the atropine is actually working to slow the myopia, even though we've got form deprivation. So it should be the form deprivation inducing around 20 diopters of myopia. But with the atropine injection, we're less than 5 diopters. So it's doing a significant reduction in the amount of myopia that develops in the chick eye. Unfortunately for our theory that it's accommodation that's causing myopia, is that chicks have skeletal muscle for their ciliary body. So the atropine has zero effect. And we can see that in the bottom figure, where we've got the lens thickness and induced accommodation using carbachol, which will stimulate the skeletal muscle in the ciliary body there and induce accommodation in the chick. And regardless of whether it's just saline or atropine that's injected into the eye, we see that accommodation still occurs. So in the chick eye, at least, accommodation is still present with atropine instilled, but the atropine is still preventing the myopia from developing. So this leads to the theory that the atropine is working through a non-accommodative mechanism in the development or the inhibition of myopia development. So next slide, please. So one of the main side effects of using higher dosage of atropine is obviously the cycloplegia, which is the reason it was first used, but also the pupil dilation. And so if we've decided now that atropine is working through a non-accommodative mechanism, if we can reduce the dosage of atropine and thus reduce some of that cycloplegia and the pupil dilation, these side effects, it will make it more tolerable for our patient, but can we still get the same sort of effect in terms of myopia control? Well, if we have a look at both the accommodation on the right and the pupil dilation on the left, there's a dose response with atropine. The greater the concentration of atropine, the greater the side effect. So on the right, we've got accommodation, and we can see that for the low dose atropine, so 0.01% or 0.02% atropine, so very low dose atropine, we're reducing accommodation by about 2 to 3 diopters. For 0.05% atropine, we're also reducing it by about that same amount, about 2 diopters. So if you think in terms of a child that you're going to be using atropine on to try and control myopia, they're going to have 15 to 20 diopters of myopia, 15 to 20 diopters of accommodation available. So what this means is that a 2 or 3 diopter reduction in accommodation is not really going to impact on the amount of accommodation that they have available. So a lower dose is going to get rid of a lot of the side effects that the high dose 1% atropine would give to the patient. Likewise, for the pupil on the left, we can see that above about a 3 millimeter increase in photopic pupil size, we start developing significant discomfort. So if we can reduce the dilation effect to below 3 millimeters, we're going to have much more comfort for our patient, both in terms of glare, but also in reducing aberration. And you can see that those low dose, low concentration atropines, so the 0.01, 0.025 and 0.05% are all keeping our pupil at about 2 millimeters maximum dilation. So below that 3 millimeter threshold where we start getting side effects. So low dose is really good for reducing the amount of side effect, but do we have a similar reduction in myopia development that we get from the higher dose atropine? On the next slide, please. We can see that from ATOM 1 and a newer study, LAMP, we do see that. So ATOM 1 and 2, the atropine for the treatment of myopia study, and LAMP is the low concentration atropine for myopia progression study. And this is a much more recent study that just came out earlier this year. So you've probably seen the figure on the left before. So this is ATOM 1 and ATOM 2. And you can see for the first 24 months, they were looking at 1% atropine, which was the standard dosage, and then progressively lower dosages of atropine. So the 0.5, 0.1, and 0.01%, and then placebo right down the bottom. And you can see that just like with the side effects, we have a dose response in terms of the myopia control as well. 1% gives us our greatest control of the myopia, but we still saw a reduction in myopia progression at 0.01%. And so ATOM 2 did a washout and looked at what happened when you stopped treatment, and everyone started progressing again in the next 12 months. And so then they started them all back up on a low dose, the 0.01% atropine, and had a look at what happened over the next couple of years. And what you can see from the 0.01% atropine is that by the time we get to 5 years at the end of the ATOM 2 study, we've got about 1.4 diopters of change in our refractive error, which is equivalent to the placebo group at the 2.5 year mark. So in 5 years, we've slowed the progression of myopia by about 50% compared to the placebo group. It's taken 5 years to get to the same point that the placebo group got to in 2.5 years. If we have a look at the LAMP data, they have just published 2-year data. We see that same dose response, that the higher the concentration of atropine, the more control of myopia we have. So this is really good. We're reducing, even with very low doses of atropine, we're reducing the amount of myopia that is developing in these children. But remember back at the start where I talked about the fact that myopia is mostly axial in nature, and all of the pathology that we see is due to axial expansion. What's actually going on with the axial length of this low dose atropine? On the next slide, please, Sam, we'll see what is happening. So interestingly, ATOM didn't really look too closely at the axial length, and that's where LAMP has really excelled, that they've looked at the axial changes as well. In the top right figure we can see here is looking at axial length change in the first year for LAMP, and in the first 2 years for the ATOM, looking at that 0.01% atropine and the placebo. And you can see that in terms of change in axial length, there's no real difference in axial elongation between that low dose atropine and the placebo. So while low dose atropine is controlling the amount of myopia, it's not really controlling that axial elongation, which is where the pathology is coming from. So that's not really doing what we're wanting it to do in terms of reducing the morbidity associated with myopia. If we have a look at the LAMP data and the ATOM data in the graph on the left, this has been plotted against a couple of other studies. So against the COMET study, which was looking at progressive addition lenses for controlling myopia, which has been shown to have a statistically significant reduction in myopia in terms of axial elongation, but not a clinically significant reduction. So it was less than a quarter diopter per year in terms of the reduction that we saw. The Romeo study, on the other hand, is looking at orthokeratology, which we know works very well with myopia control, and looking at the axial length changes there, both at 1 and 2 years. And what you can see is that from both the ATOM study and the LAMP study, the 0.01% atropine is sitting at or below the axial elongation control that COMET had. So COMET is widely regarded as not being clinically significant. So our 0.01% atropine is really not doing what we want it to do in terms of controlling the axial length. But we'll have a look at the LAMP 1-year data at the 0.05% concentration, and we're getting similar sort of control in terms of axial length reduction that we get with the orthokeratology. So it's looking like now that the 0.01%, while it's reducing the refractive component, is doing through not by controlling the axial length. It's probably controlling either the lenticular or anterior chamber or corneal changes, rather than that axial elongation where all of the morbidity is coming from. So at least from the 1-year LAMP data, the 0.05% is the way to go now, because we're actually controlling that axial length as well. Bottom right just came out this year is the 2-year LAMP data, and you can see that that trend continues on in terms of axial length cessation, and so stopping that growth. So it means that even after the 24 months, we're still seeing a reduction. And this is a criticism of atropine sometimes, is that we get a tapering off potentially in effect. But it looks like that 0.05% is continuing to give us, at least over the first 2 years, that reduction in axial length that we want to see to reduce the morbidity in the eyes. So moving on to the next slide, please, Sam. So if you are wanting to prescribe atropine, as Alex has already mentioned, we've only got 1% atropine available in Australia. So for prescribing it for myopia control, we have to do it off-label. This has to be ordered from a compounding pharmacy. So Slade Pharmacy up in Melbourne will be able to compound that for you. But when you're asking and requesting this, you need to put on the script to be compounded or must be compounded. There have been a couple of cases where patients have been given by pharmacists a 1% atropine as opposed to 0.01%, because I thought, oh, well, this isn't available, and so therefore I'll just give them the 1%, or maybe they've written it wrong. So make sure that when you're ordering these low-dose atropine, you put to be compounded or must be compounded on the script to make sure that the patient's actually getting what you want. Otherwise, they're going to come back to you with some quite significant side effects of complete loss of accommodation and really large dilated pupils. So next slide, please. But there is a bit of a caveat. Even if atropine is working to slow the progression rate, we don't see the same response rate in everyone. So some myopes don't respond at all to atropine. So you can see that even in ATOM 1 with the 1% atropine, so the highest dose of atropine that we typically give for controlling myopia, about 12% of people on that 1% atropine still had a greater than half a diopter progression per year. So this is also dose dependent. So the lower our dose of atropine, the more people we have that are showing a poor or non-response to atropine. So when you start a patient on atropine, monitor them for 6 months and have a look and see if there is actually a response in terms of slowing the myopia down. If there's not, you might want to push it out to 12 months. But at that 12-month point in time, if you've still got this fast progression, you might want to up the dosage of atropine, but it's more likely that they are a poor responder to atropine, and you might want to consider a different treatment, one of the other treatment types that we've got available to us. The next slide, please, Sam. So this is showing us some of those other management options that we have. So you can see that atropine is ahead of the pack in terms of that myopia control, but orthokeratology and soft contact lenses, so these are dual focus or multifocal soft contact lenses, also give us pretty good myopia control as well. Particularly now that the MySight soft contact lens is available from Cooper Vision widely across all practices in Australia now. The red line I've drawn there is showing you the 30% reduction in myopia. So that's that sort of sweet spot where we're getting at least 70% of people not or 70% reduction in people clicking over into that high myopia. And so you can see that Ortho-K and those multifocal soft contact lenses are achieving that for us. And they're even, in some individuals, achieving it at that 50% reduction rate as well. Atropine is better, but if your patient's not responding, Ortho-K or soft contact lenses are another option. And next slide, please. And the next thing that's sort of coming along is dual therapy. There's really been very few published clinical trials looking at whether we can add atropine and another myopia control management option together. This study just came out earlier this year, looking at Ortho-K, which we know works very well with myopia control, and seeing what happens when we add atropine to it. You can see on the left slide here, left figure here, the monotherapy group in the triangles, which is just the Ortho-K. Now we know that Ortho-K is slowing the rate of progression. So over 2 years, we've got a slowed progression rate. But if you add atropine on top of the Ortho-K, you actually get a significant further reduction in the change in axial length. So we're slowing it down even more. So that's a really promising sign. When the researchers split that out into the low and high myopes, and we can see that on the right-hand side, the low myopes were the ones that showed the benefit. So people between 1 and 3 diopters, if you added an atropine on top of the Ortho-K, you got a very significant reduction, an additional 50% reduction in terms of axial elongation. In the people who were above 3 diopters, we didn't see that additional effect. So need to take this with a pinch of salt. It's a very early look at this data. It's the first study to really report this, but watch the space because a lot of further data is going to come out on dual therapy. But it looks like if you've got a patient who may not be responding particularly well to atropine alone, adding Ortho-K in, there may be an additive effect, and you can potentially really show good control of their myopia to really slow down that progression. But there's going to be a lot of studies coming out in the future looking at low-dose atropine and whether it can have an additive effect with other treatments as well. Next slide, please. So to conclude, the pathology associated with myopia is due to that axial elongation. So we really need to be targeting our therapy to reduce that axial elongation. Now we use in practice often our refractive change as a proxy for axial elongation. If you really want to get serious about managing myopia, you really need to get a device such as a LensStar or IOL Master that's going to allow you to measure that axial elongation, because that's the thing that we really are wanting to control in our patients, to stop that axial growth, to reduce that morbidity. So 0.01% atropine, which is what everyone's really been using for that low dose atropine, it reduces refractive progression, but we've seen really minimal effects on the axial elongation. So it's not really giving us the response that we really want. And it's looking like now that 0.05%, again, it's just one study, but there's more studies coming through that are starting to show this as well. But 0.05% seems a much better dosage in terms of reducing that axial elongation, but there's only a really minor increase in terms of pupil size changes in cycloplegia over and above the 0.01%. So we're still within that area of minimal side effect, but with actually controlling the myopia quite well. Remember that if you start managing a patient and they're not responding to atropine treatment over that first 6 to 12 months, you may want to start a dual therapy or change them over to a different modality such as Ortho-K or a dual focus contact lens. And that dual therapy is starting to show early promise, but we need more studies in the future to really see exactly what sort of benefit and additional benefit we can get from adding atropine in with some of these other modalities. Great, thank you very much.
Thank you so much, Simon. That was excellent as well. We really appreciate you joining us tonight. We have a lot of questions coming in from the audience for you. The first one off the rank is, at what age does myopia stop progressing? I recently had a 26-year-old patient and was wondering if it is worthwhile to start myopia control.
Yeah, it's a really good question. So the majority of myopia is obviously school myopia or the lower myopia that's starting at a younger age, so around that sort of 7 to 8 years of age. And it tends to stop around our late teens to early 20s. If you've got someone who's started or continuing to progress in their mid to late 20s, that doesn't really fit into that sort of normal school myopia. Not a lot of research has been done onto treatment for that because it's not as common. The majority of people are going to start at a much younger age. So there's nothing stopping you from trialing it, but I think you'd need to temper your patient's expectations, saying, look, this works in younger children. We don't know about the older age, but there is the potential there for it to work in your eye as well. But you need to really let them know from the outset that if we don't see any change, then we might have to go to a different modality like ortho-K or something like that.
Great. And just one more question, Simon. So I think I asked this at a conference a few years ago, but at the time there was no study on it yet. Has there been a study where you could do a short-term 1% atropine to more fully control the myopia, then switch to a milder dose so that you can see progression and look at its effect on managing progression and side effects?
Yeah, as you say, there hasn't really been any studies that have looked at that. There's nothing stopping you in your practice doing that. I mean, obviously there's a greater side effect with 1% atropine. And at 1% atropine or the higher doses of atropine show a much greater rebound effect. So 0.01% atropine doesn't really show much rebound when you stop the treatment. But I suppose from your question, if we did sort of a pulse dose like we do with steroids, do a high dose 1% atropine, stop it for a little bit, and then move on to a 0.01% or a 0.05%, there is the potential that would work. And that's sort of what Atom 2 did, that they had the people not on the 1% atropine, but the 0.5% and the 0.25% atropine that came off of it started showing an accelerated progression. And then they put those people back on to a 0.01%, the low dose atropine, and they actually showed again a slowing of the myopia progression. So you potentially could hit them with a high dose of 1% for a short period of time and then move over to a lower dose. But as I say, there's no studies that have looked at that as yet. I think most people are focusing their research efforts on the low dose and whether that's going to be sufficient in the longer term.
Okay, thanks so much, Simon, again. And thank you everyone who presented tonight, taking the time out of their busy schedules and teaching us a little bit more about therapeutics. That's all we have time for tonight. And sorry we went over time, but we just decided the value of the content was so great we'd continue. So thanks very much for joining us for this interesting session. And thank you to our listeners for tuning in and participating in today's webinar. We hope you join us again next time.
That's right, Amanda. Thank you. So please feel free to provide any feedback regarding tonight's webinar, the presenters and their presentations through your Qualtrics survey, which has been shared via the chat function in this webinar and will also pop up again as you exit the webinar today. The Alumni Committee would love to hear from you, so feel free to reach out to us at any time. We would be interested to know about also if anyone is wanting to get involved with our committee. So in the link, there will also be another link available for anyone who wants to apply for a position with the committee. So the next step now is to fill out your CPD questionnaire to earn your CPD points. As I mentioned at the start of the webinar, we will be using the Qualtrics app. The quiz will be available for the next week, so you will have plenty of time to complete this questionnaire. Please also update your contact details with the Alumni Committee so that we can actually keep in touch with you. And also feel free to follow our Facebook or Instagram pages, because that way we can provide you with regular updates and you can see what we've been up to. We would like to remind you also that on the 8th of October at 11 a.m, it's the Online Alumni Awards. So if you would like to attend, just give us a shout out and we can provide you with more details about that. And other than that, thank you so much for joining us. Until next time, goodbye from the alumni team, and thank you for your continued support. Good night.